think everything will be very clear on its own. So I think in order to understand how to improve vision in someone living with keratoconus, I think we first have to understand how generally vision works. And this, I think, can also go a long way in helping those who may not have the condition, but who may be family and friends and, and surrounding the patient and understanding how to lend support to your loved ones. And so I think it is important to understand how vision works. So when I bring up the first slide, you will see basically a cross-section of the picture of the eye. And quick, no one looks so that you don't blow my punchline. So a cross-section of the eye as seen here, and our vision generally works very similar to, as many people like to say, a camera. Right? So you have a focusing unit at the front that basically controls what image is being projected to the back, which is the film, and that records the image. So very similarly, if you can see my clicker right here, so the front portion of the eye is composed of your cornea, which is the very outer element and the very first element that visually interacts with the environment. And you have this round structure right inside of the eye, but behind your cornea, and that's called a crystalline lens. Together, the two units basically add up enough magnification power to produce an image from the outside, the physical space, and bends light properly so that the light rays that carries these image information can be properly projected to the back of the eye, produce enough signal strength to produce an image that is reversed in its orientation and later on being processed and prepared for your viewing. So why is that important? Well, in someone with no eye condition, and that includes no glasses prescription, the eye works just perfectly with a very round structure, very smooth curvature of your cornea, as seen right here, so that all the light rays are being bent in a very controlled fashion and focus into one single point, or at least in close enough of a proximity for you to see a very single clear image. However, what happens in keratoconus, just like Dr. Hirsch had pointed out earlier, as the tissue starts to weaken and distorts itself, you slowly lose that smoothness, that smooth curvature that you see on the other side, and therefore the magnification power across the whole cornea is no longer the same point by point, so that the light rays are now started to be dispersed in a random fashion, and therefore one may see multiple sets of images. It weakens the signal to the back of the eye because you're not getting all the information close enough for you to process, and therefore image may appear to be very washed out. Things may look blurry, but yet nothing can help. And this situation exaggerates itself as the condition gets worse, as the cornea further deviates from what it once used to be, a very smooth, rounded structure. So while we're on the point of a camera, I just thought that it was fun to know that you could also make a camera out of regular items like a watermelon. And also an egg. You can make pinhole camera out of these items. So is that really it? Is our vision just as simple as a camera with some sort of focusing units and then a film in the back of the eye, which obviously is your retina? Well, obviously, if that was it, then I might as well end my talk right now, right? So no, that's not it. But it is very close to how camera works. But unlike a simple camera, our vision is more similar to, if you will, think of a digital camera. And what's the difference? Well, a digital camera has more than just the power component of your focusing lens and some sort of recording device like a film or like a SD card or memory stick in the back of the eye. But you also need a processing unit. You also need a connector between the camera and the processing unit. So many of us may, have a USB cable, that's your connector, and then you have a computer that you download your image upon for further processing, and that would be your brain. So you could see the structure linearly in the back of the eye. That's your optic nerve. So that's where the impulses or the message that is generated by your retina carried by these cables, if you would, to your brain for you to process. So any of these four basic components of your vision, if that's not working properly, you don't see regardless of how healthy your eye is. And therefore, it has important implication for us when we are taking care of patients and trying to improve their vision, because it's more than just the sum of its parts, and it's more than just what you see in each eye. So we also have to pay attention to how this information is being processed in your brain, which is what a lot of people tend to forget, patients or doctors, and therefore may experience difficulty with the outcome of a recommended procedure. So we'll go through that in a little bit. But even the most sophisticated camera can create image that is unintended by the external environment, such as what you see here. Under the right setting, under the right lighting, with the right timing, you may see things that you didn't think that you see, such as this photo, and I did not take this photo, called the face of Paris. Okay, so what does that demonstrate? That demonstrates that there are tendencies in our brain that can be misled in these situations that we often sort of just write off as optical illusion, right? So in order to demonstrate further how your vision works, and those who are fortunate enough who can actually see what I'm projecting on the screen here, I'm going to show you a series of let's call them exercises. I'm going to show you a series of illustrations, and I want you to just yell out what you see. And don't be afraid, there's nothing dirty. I tried and I couldn't find anything. So remember, I just want you to yell out what you see to me, okay? I'm not offended. So there you go. What do you see? Yeah. So I heard most people say two vases, and I heard someone say a vase or a flower vase, right? So this is no more than a composite of shaded area intervening with an area without shade. And yet we can see completely different things. So and there's another one coming, and again, I want you to just yell out what you see. How many? 2. So I heard someone say 1. I heard some people say 2. So here you have a very young, elegant lady, and if you look at the whole face this way, you see an old lady, right? So again, what does that mean? Again, nothing more than just a few line sketches, black and white coloration. There's nothing sophisticated or nothing, extra artificially manipulated. But you can see how everybody sees things differently, even though it's the same thing. And what does that mean? That means that your brain has tendencies to perhaps has the ability to fill in things that it's not either paying attention to, or things that it's sort of just glossing over and ignoring, because you don't need 100% of the visual information to be able to process where you are and what you're seeing. But that does lead to a situation where our brain, not just our eyes, but our brain can be misled into seeing things that other people may not see, and therefore living with a visual impairment, such as in a condition as keratoconus, can then create sets of challenges. Whether it's in an artificial environment, such as seen here, or a natural environment, such as accessible as your backyard. So here you see a set of stairways that seemingly extends its way into beyond where the end point of the stairway is. And you can imagine if this were a situation at nighttime when you actually don't see the outside beyond the glass panel, what may actually happen to a person. And that's where injuries can obviously occur. And here some people may see just a very beautiful butterfly with flower sort of hanging below the branches, and some of you may actually see that it's basically just a lot of birds sitting close together without personal space. Right? So again, maybe, and so what does that all mean? Maybe these are just temporary optical illusions. Some are, some are unfiltered, exactly the way it's taken. But what does that mean to us? Well, it may be fun when we are just looking at photos, because at some point I'm going to run out of things to show you, right? So at some point it's going to end. So it feels good and it feels like it's a lot of fun. But imagine if you are someone who's living with this all the time and there's no controlling it, and you can't walk away from it. You perhaps can shut down and close your eyes, but then what are you going to do? Right? So you are living under a very restricted situation, and where people may not understand. And there's one more thing that I want to show you, and this does go to demonstrate a point. There's nothing, there's not an optical illusion here really, but if you cover one eye then cover the other, you obviously see that it's a flat image and you see two circles on each side. And most of you are just looking at this straight on because it's harder to do at an angle. But if you slowly try to look at the image and cross your eyes until you can put the two circles together into one, with both eyes open, the two circles on the side would become a little bit more defocused and blurry, and the one circle in the center, once you're able to get the eye strain feeling to cross your eye, you'll see that a more clear image is being seen in the center, in front of the two circles probably, and where the lady's face is right now that's missing, you'll be able to look through it like a telescope, and you actually start to appreciate depth of the back alley or the street. Can anyone see it? Yes? Okay. So again, what does that demonstrate? That demonstrates that your vision is more than the sum of its part. It's not just how one eye sees, because each eye sees a very flat image. But when both eyes are working together, when you're being instructed and follow my instruction, you actually start to see different visual cues. So there is a benefit of being able to provide input from each eye to your brain. And unfortunately, if you have a disease, if you have a condition that does not allow your eyes to function close to each other's level, one eye meaning one eye is very blurry, one eye is not, then you don't have the ability to be able to receive extra visual cues that guides us, those of us with normal vision, quote unquote normal vision, to be able to walk around and to be able to sort of orient yourself in space as we all do. And so that again is something that's often ignored when you are focusing on improving your vision, and especially usually the worst eye, given the fact that this is a condition that has worse in one eye than the other. So that again presents another challenge that we often have to pay very close attention to when we're providing consultation and comments to patients who are confused about what is going on. So, enough with the photos, enough with the pictures. What exactly are we talking about? Well, the conditions that I have, the illustration I show you with the light being dispersed randomly across the back of the eye, before, basically creates a set of consequences that we call optical aberration, or what I like to call as visual noises. So sort of like watching a satellite TV when the weather's really bad outside and your image quality, you have a lot of snow on your TV screen. It's basically, think of that as the same thing as someone who is living with a corneal condition such as keratoconus. And there are reports that shows that these optical noises, these optical aberration is more than 5 times more in people with keratoconus versus those without, and that's a huge number. And perhaps the silver lining here would be if we have the ability in the future to very accurately capture these optical aberrations, and we do have the instrumentation now, but the consistency and sort of reproducibility can improve in the future. But what that means is we potentially can then utilize that in whether surgery or non-surgical methods to counter the exact noises that each person individually is perceiving, and hopefully be able to restore their vision back to where it once was. And so some of the symptoms, what does that really mean? Mathematically, it's more than 5 times more. What exactly are we talking about? Well, let's talk about symptoms. Some of the common symptoms that keratoconus patients experience. And as you can see those diagrams, as the stage of your keratoconus or someone's keratoconus progresses, the more exaggerated that dispersion of light ray that occurs in the back of the eye, and that may potentially lead to many washed out ghosting images that are being seen all at the same time. And you may say, if one moon is really beautiful, what's wrong with multiple moons, right? Isn't more the better? Isn't that American, right? So So yeah, that is true. Potentially, you may think that that's really pretty, but in those of you who are making noises right now, who are looking straight at this photo, if you are experiencing some sort of visual discomfort, if you're looking straight and staring at it and thinking, well, I wonder why. Well, and this is only 2 images, right? I mean, this is only sort of overlapping 2 images. It's not even completely double or more than double. And this shows you, again, that although I could voluntarily have you do eye exercises and try to make a third circle out of 2, there are also involuntary visual reflexes in your brain that you cannot control. And therefore, if you're experiencing these optical illusions, that won't go away and you can't control. The only thing that you can do is basically shut down your whole visual system so that you don't interact with the environment, right? So those are also things that we're trying to prevent and trying to help other people with. And what about another common symptom like starbursting? People talk about that a lot. Sometimes all day long, sometimes only more at night, and also obviously depending on the stage of your condition. The more severe it is, the more affected that you can be by it. And some of my patients either quote unquote choose to not to go out at night, and some of them can't even go out during the day when it's sunny because there's so much glare and it's so light sensitive. Their eyes are hurting so much, even with the darkest sunglasses that they can find, they still can't go out. And so imagine a life like that. And again, you may look at this photograph and say, well, that's rather pretty. It's like, a masquerade where you see the headlights kind of coming up this way. Well, that is true. And maybe some of you are thinking, well, it only affects a small group of people, and it doesn't affect me, and I can maybe I be the one who's driving my friend or my loved one around the town all the time. But are you really able to do that all the time? And are you really able to provide that kind of unconditional support at all times? I think most of us will admit that that's difficult, right? And those of you who may think, well, it affects a small group of people, really, and what kind of consequence does that carry if it affects maybe 1 in 2,000 or maybe a little bit more? Well, if you're the person standing right there next to a driver who is driving with keratoconus, I think you would look at this situation a little differently. It doesn't just affect one person or one group of people. It affects everybody in the whole community surrounding these patients. So really, what's the worst that it can happen, right? I have no sense of direction, and now I got a new iPhone. This could have easily happened to me. So exactly what kind of implications are we talking about? Well, and I think this goes into there's a stigma, at least the way I see it. I think there's a stigma associated with people with this condition, and by that I mean you on the outside. This is such a small anatomical deviation that cannot be seen unless we use our clinical instrument to be able to diagnose you. It's not something that anybody can visibly see. And so you on the outside as a patient with keratoconus appears to be very young, very healthy, and people look at patients with keratoconus and they don't understand. There's no sense. It's very difficult to have sense of empathy because you can't understand where the problem is arising from and why people are so restricted in their mobility. But there's a study, one of the largest study involving keratoconus patients called the CLEI study. It enrolled 1,209 patients across 8 years of follow-up. And part of the study looked at utilized a questionnaire that was devised by National Eye Institute, and part of that questionnaire looks at what we call the mental score or mental health aspect. And that involves patients self-rating themselves in terms of how they perceive themselves. And it was found that keratoconus patient, through this study, that you can see those numbers that I put behind each condition is somewhere between macular degeneration stage 3 and stage 4. And you're, again, comparing a completely different spectrum of patients. We all are aware of what macular degeneration is, and because of the respect that we have for our senior citizens, I think it's much easier for us to have empathy for patients with macular degeneration. And that's the stigma that I'm talking about with people or patients with keratoconus. They are at the other end, potentially. They're much younger. They should be more productive, if you, at least maybe work-wise. or establishing themselves as this disease happens in early stages of life. So, so it does carries with itself a lot of consequences as these young people set out to lead their lives when they are being hindered very early on with this condition. And the three words that we could not avoid hearing in the past year on TV is what? Jobs, 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 right? So as American, we care about our economy. So what does this condition really have to do? As much as I've tried to describe the visual conditions and the symptoms that we experience as keratoconus patients, what does that really mean to us as a community? Perhaps you're still not convinced of what I had said about how this condition also affects those surrounding them. Well, if we look at different medical literatures that have been reported, in 2007 there was a study that was published in Ophthalmology that had reported that corneal diseases, which is ranked number 5 as the top eye condition, it is estimated that the indirect cost in 2003 to just Medicare beneficiary, indirect care cost, and that means they potentially damage their body parts or bodily damage, injury that is sustained due to visual impairment. Just that alone is $2.14 billion. And that's not even including direct care cost, although in this report, indirect care cost obviously is more because you could damage more parts of your body. And let's look at the group of people with keratoconus that are actually fortunate enough that they could go out, they're not as restricted, and they can find job and they can work. If you compare people with low vision, people with visual impairment, versus people without, those with visual impairment on average lose about 12.9 work hours per week. That's more than a quarter. And that's a report that was released by Johns Hopkins School of Public Health. And there's also a study done that was reported by a very prominent research institute in Boston, looking at the benefit of restoring someone's vision using a specialized contact lens device, and it was found that, or it was estimated that the economic gain per year was $10,000 to patients just having these devices properly fitted to restore someone's vision. And that's obviously above the cost that they have to afford to actually get these devices made and fitted, which is not a low number according to this report. So you can see that these conditions can obviously affect someone's work productivity and even just in generally their ability to make contribution to their country, to their community. So obviously this is a condition that we should all be very careful and be mindful about and also very understanding of. So what can we do? So, and I know I'm being a little corny here. People call your eyes as the window to your soul, and here I'm showing you a windshield. But I was always told that I should stick to what I know best. So this morning, corny is my best. And if you look at, so let's say you're driving on the highway, you get hit by, something that's falling off the truck in front of you. And then you have a little chip or a little divot on the window shield. Depending on the location, depending on how severe that defect is, you may have no choice but to replace your whole windshield, and that would be analogous to a corneal transplant, which is at one end of the treatment spectrum. Or you could choose to reshape your windshield so that you can restore the surface integrity and the curvature that it used to be by maybe injecting a liquid material into it and allow it to sit and settle and reform itself. And that can be done either non-surgically with a contact lens device, or that can be done surgically, which Dr. Hirsch will be covering as well later on today. So I'm going to just, for the rest of my talk, concentrate on utilizing contact lens devices to restore someone's vision. So what are we talking about? We're talking about a pair of glasses, because I get asked that all the time. And what is the difference if my friend can put on some sort of soft lens that they see on TV and be able to see, why couldn't I put on soft lenses? I, as in, someone with keratoconus, why couldn't I just put that on? And if I could see with soft lenses, why couldn't I see with glasses? And those are the sort of circular logic that patients get into, and even family, all the time. So why couldn't I just get glasses? Well, if the problem fundamentally is the shape of the eye, as we've described, then if you look at the glasses, I have a spectacle lens or glasses sitting in front of this eye. There is a space in between the eye and your glasses, and therefore you fundamentally don't fix the problem. You haven't really done anything about the shape of the eye. If you put a contact lens material, a device on the eye that has integrity, that's able to maintain its curvature, its smooth shape on the eye, you then form a seal system with the eye that completely covers the distorted shape of your cornea. And therefore, when the light comes and it first interact with the contact lens, and it basically is being bent or refracted by the contact lens as if it were part of your cornea, and therefore you actually bypass the issue with the distorted corneal surface. And that's why a contact lens, typically not a soft lens, but that's why a contact lens device can work in this situation. So what are some of the options? Many of you probably have already heard about, stories from your support group, if you're in one, or have looked up online about all these hard lenses, quote unquote. They're not really called that anymore because the material is different. There's no hard lenses anymore. And those of you who are still wearing hard lenses, you should probably stop. And because there are better designs out there right now. So we call them gas permeable lenses now, because the new material is much more biocompatible with the tissue, and also allows much more oxygen into the eye, so they're called gas permeable lenses. They have various designs that overcome the previous issues faced by many patients, such as pain and discomfort, and lens sort of popping out. And you can see why, because this is a gas permeable lens that a patient came in wearing, not fitted by me. And you could actually, as a side note, you could actually start seeing all the gunk material that has been built up at the bottom of the lens, and she's complaining of discomfort, and she doesn't understand why. And obviously I changed the fitting of the lens, she feels much better, but also replacement of your devices is something that most people are not aware of, and that can also lead to your frustration of, why does something work a year ago and now it's not working? Is it me? Is it my eyes? And typically, obviously see a professional and see your doctors and get the questions answered. But a lot of things can start as simple as just getting new devices and knowing when to replace them. And one of the reason why these hard gas permeable lenses are so difficult to get used to, you can see that most of the time it's rather small, and it's usually smaller than the size of your cornea, which is right here. And this one is extremely small, but normally it's smaller than the size of your cornea. And your cornea is one of the most heavily innervated tissue. That means has a lot of nerve endings, and therefore is very sensitive. It's exquisitely sensitive. It can create a lot of painful responses that the toughest person in the world will not be able to handle. And therefore, by placing or leaning an object against your cornea stimulates the pain receptor until full adaptation or desensitization occurs. And that's why it can take such a long time for someone to get used to gas permeable lenses. However, when it does work, which is why it has been a gold standard in treating patients with keratoconus, when it does work, it works wonderfully. So what are the other options if we're talking about sort of pressure, the weight distribution on the cornea by these lenses and causing discomfort? Well, maybe what we can do is we can layer a soft lens underneath the gas permeable lens in an approach that we call piggybacking, which sounds like a lot of fun. And it can be, I think, if you have the right mindset. However, and we can also potentially use a very specialized soft lens and create a cutout in the center and actually create almost like a housing unit for the rigid lens to go into. And that's another type of piggybacking approach. And the benefit obviously is the weight distribution, or this pressure exerted onto your cornea is being absorbed by your soft lens, and therefore the lens can be much more comfortable for those, initially at least, for those who could not get used to gas permeable lenses, and still provide the same visual benefit of being able to see as well as one does most of the time with gas permeable lenses. Sometimes people worry about the complexity of having to take care of these devices every day. Does that mean it doubles the amount of work? Actually, not quite. I mean, we have better solutions now. So again, it's something that I would urge you to obviously explore if you're struggling with your current contact lens device, and that being a gas permeable lens. And so from the idea of the Piggyback, if we could put two lenses together, why couldn't we just fuse two lenses into one and use that? And so, someone was very clever into thinking that up, but the difficulty was finding a good process to be able to manufacture and to be able to fuse two different materials together without them falling apart. And so these are called hybrid lenses. And as you can see on the picture here, there's a specialized design of this lens that it kind of arches up in different in this location right here where my pointer is pointing to, and that typically is where we think keratoconus tissue, where the distortion and the bulge that falls forward, so that by being able to approximate and change the shape of the lens from a very simple one curved lens into this type of formation, you're able to sort of house or accommodate the bulge a lot better, and therefore you can protect the area of the keratoconus that falls forward, and therefore you also do not stimulate and do not touch the cornea, and that's why the lens can also initially be a lot more comfortable than a gas permeable lens. And an exciting breakthrough is that in sometime next year, this lens will be launching its newest material that allows tremendous amount of oxygen delivery to the eye, which obviously clinical science has shown that is very beneficial to the eye to have more oxygen. And therefore, we're very fortunate in our clinic that we have access to this lens already, but it will be launching this company will be launching this lens sometime next year, and I'm very excited to see where this design can go. And I'm also and I just want to mention that these lenses that I have laid out here is in no particular order. So I don't have preference over one or the other, and I'll tell you why in a little bit. I think it all depends on the individual cases of patients presenting to our clinic. And there's another category is called scleral lenses, and sclera is the white part of the eye. So as you can see in this picture, it basically has the edge of the lens now no longer. Not only does it not touch your cornea, not sitting and leaning against your corneal tissue, it actually does that by grabbing or sitting on the white part of the eye, which does not have a lot of nerve endings, which is not very sensitive, and therefore the lens can initially be much more comfortable just right from the start. And also for people it's also got some other medical benefits to people with severe dry eyes or autoimmune disorder that may have tissue destruction that's going on. This is also a lens that is very beneficial for that purpose as well. So I have mentioned the fact that soft lenses typically doesn't work. And the reason it doesn't work most of the time is, again, comes back to that distortion, irregular surface issue that we have talked about. So if you imagine that you have a broken edge on a container or your dish, and you simply put a layer of saran wrap over it, you could still see the edge. You could still feel the edge. It's a soft material. That's what soft lenses are like. It's like a very thin layer of saran wrap. So therefore, you put it on, although it may be comfortable, it doesn't really neutralize the shape factor that we're talking about for keratoconus patients. And therefore, it typically doesn't work very well. Some of the new designs out there as a custom lens for patients with keratoconus, I have to say in the past 6 months to a year, have actually been very impressive for me and my patients. And therefore, we do now have that option available depending on individual candidacy, and that means the disease of the severity of their disease stage. So that certainly is also a possibility now. And I don't know if you could see the photo here. We have a patient who had received Intacs, which is a procedure that Dr. Hirsch will be covering a little bit later, and so that it alters the shape of the eye, makes it better, and that allowing us, not maybe all the time, but in this particular case, it allowed us to actually use this type of soft lens to rehabilitate this patient's vision, and it made this patient extremely happy. And while we're on soft lenses, there's also, and I had talked about the fact that we can measure these optical aberrations using current instrumentation. And if we are able to do that, then there obviously would be the ability to maybe transfer that data, reverse it, and apply that to a contact lens, and then to be able to counter, again, all the visual noises that's being produced by a distorted surface. So that's also available out there, but it's relatively new. There's not a whole lot of clinical data right now to say which way this type of lens is going to fall. But again, I'm really excited to see where the technology is going to go. So your question may be at this point, so we've gone through some basic category of lenses, and each category of lenses have obviously numerous different brands and numerous different designs, and that I'm not going to go into because, again, that's something that should occur between you and your doctor. But one of the most common questions then, again, after I review these lens options with my patients would be, well, couldn't you just tell me there's one lens that works for me? What would be the best lens for me? And to be honest, we all want to know that. You and your doctor and us, we all want to know, well, what is the best procedure? What is the best device for any patient? And the question is, there's really not one. We did a study, a retrospective study involving 329 eyes of patients with keratoconus that was treated in our clinic. And we looked at the different type of contact lenses devices that we used to rehabilitate these 329 eyes. And although different lenses did indeed perform differently in this sample population, none of them came up to the 95.1%, which is what we found at the end of our study. We found that of the 329 eyes, we had 95% of success rate in being able to restore their vision and have them be fitted with a contact lens device. So why does none of the single lens device design come up to the 95.1%? Well, we think it's because, and this, again, is something that I hear so commonly from patients coming to our clinic, having maybe been to other places and wanting now to see if they have other options that they can do. And a common theme that I hear is, well, I've tried that. I've gone to my doctor 10 times, and I've tried 10, 20 different sets of contact lens devices, and none of them worked. And so maybe some of them are even more motivated. They go yet to another clinic, and another 10, 20 sets of devices later on, still nothing worked. But if you dig deeper into, at least when we do, you find that it has been pretty much the same lens over and over and over again. They may be different design, but they're all within, let's say, if they try gas permeable lens, then they're always gas permeable lens. But like I said, that's the gold standard approach. So there was nothing wrong starting with that first to see if a patient can get used to that. Or it could have just been multiple sets of soft lenses, and finally giving up and think, I probably need something else to be done. So within our study, the 329 eyes, we find that if we utilize just one design and given some opportunity to retool and redesign to just fit the eye a little bit better, if that still doesn't work, just by going into a completely different lens category, we raise the success rate within this group of people to about almost 20%, from 75 to almost 95%, just by going into a completely different lens category. So I think in my mind the question is not which lens is best for you, because obviously, or best for this group of patient, keratoconus patient. It really, obviously, their individual characteristic and visual processing and your sort of, your that is happening in your visual cortex that everybody's different, so that there are other individual factors that we have to pay attention to. But just the fact that you are able to be open to be fitted with different type of devices may actually allow you to have much more success with being able to see. And I say that because that's not just with your doctors, but that's also with patients. I've seen patients who come in and say, nope, all that I want to try is this. If my friend can wear a soft lens, why couldn't I be fitted with a soft lens? That's all that I want to try. So that person may go on to across the world to different clinics in different countries, but yet all that they're not open to all the other options available out there. They are open to going to somebody who's going to make their idea of having one type of lens work. And so this applies both ways to doctors and patients. We have to keep an open mind, and communication is really important. And the other result that we have found to be that we were pleasantly surprised was the fact that if we look at our study cohort, and if we break them down to people who have been recommended surgical approaches, a treatment that Dr. Hirsch again will cover later, and people who just go straight to contact lens fitting, we find that overall in the study, on average, about approximately 1 in 2 people, so that's close to 50% of people who cannot tolerate contact lenses that they were given, and that's why they present to our clinic. But if we break them down into those who decide to go for surgery and who decide to maybe be open enough and give contact lens device a try, you could see that their tolerance rate is very different, and that makes sense. Those who have trouble, whether it's self-perceived trouble or really legitimately that they've really tried everything out there, obviously will decide to or would choose surgical approaches. So that's not surprising. And obviously the reverse is true. Those who sort of has somewhat of a trouble or problem with contact lens devices, but maybe not enough to be completely frustrated, will choose to maybe try contact lens devices first. But what's surprising is if you look at the success rate or the tolerance rate afterwards, the huge jump that you get from in the surgical group, going from this number to 98.5%. Although that may be statistically the 95.8 of people right here, success rate of people without surgery to the 98.5% with surgery, although that may not statistically be significant, but if you compare that to their tolerance rate or their history with contact lenses prior to coming to our clinic, that becomes a huge jump. And so what does that mean? That may potentially mean that there is some benefit of having a combination approach of having surgical approaches to make the shape of the eye a little bit better, and then come back to being fitted with a contact lens device, because it would be a completely different ocular environment. Your eye will be shaped differently, and then potentially be able to have much more success with contact lens device afterwards. And I say that because we used to think that people should have one or the other, or at least patients used to think so as well. Either I go for contact lenses, and if that doesn't work, I want transplant, and transplant means I don't need contact lenses or glasses afterwards. I should be able to see with new tissue. And that's what people used to think. You have one or the other, but not both. But I think that there is benefit to having both, at least as evidenced by what we did here. So, it's all very great to say that contact lenses devices, when appropriately used and fitted, solves everything. Well, not quite. Just like all procedures out there, just like all options that we can offer to our patients, there are certain not downsides, but there are things that we have yet to improve upon. So, for example, there are some studies that have found that even with the most comfortable lens device that someone is wearing, there's still certain situations, like in a low contrast situation, which means the lighting is really dim, for example, that keratoconus patients can still have reduced visual performances. Their vision is much improved with a contact lens device, but given the suboptimum setting, they can still have impairment that may linger, and again, that may be confusing to patients as to, well, why am I still having issue when I am already wearing contact lenses that the doctor says should be the best for my vision. So that obviously there are things that we can work on, and the report out of Boston suggested that maybe a custom set of lenses can be beneficial. And what that means is maybe in the future utilizing better technology to measure these optical aberrations or visual noises and be able to engineer that onto or apply that onto the lens so that you can cancel out all the noises that are being seen by a keratoconus eye. and also potentially maybe combination therapy, like I have mentioned, and just have better understanding of what these means to not to just to our vision, but also to our keratoconus patients. So really, what are the goals of what we're trying to accomplish here, having gone through the symptoms and trying to understand what people live with, but also different devices? Well, I think the main thing is we have to be open-minded, and that we have to very creatively use the technology that's available to us to fit our patients, and most importantly, to fit the devices to the patient, not patient to device. And what I mean by that is the scenario that I've gone through with you, where patients may go to different clinics and they're repeatedly being given similar type of lenses because we tend to think that that's the best for patients, so patients should just get used to it. But that's not necessarily true. It's a two-way street. We also need to pay attention to all the different processing, all the neural factors that I had talked about, but also what is happening to this patient's life. What's their real environment like? I mean, what would be the easiest for them to be able to accept a device to be worn on their eyes? So there are things that, requires communication and commitment of time. And as technology becomes available, as the disease progresses, which we have other procedures that we will talk about a little bit later that may be able to stop the progression of the disease, and as the lifestyle changes, for example, maybe now a patient goes from not being able to work to being able to work, and so now you're constantly on computer doing paperwork, and that may bring about a whole set of different challenges that require maybe different type of devices or maybe reading glasses, if age appropriate, that kind of thing. So the main thing is to understand that there's not really one device or one procedure that is best for the eye. Again, it depends on individual scenarios. But if you given some open honesty communication, given some commitment in terms of the time that you're willing to invest with your doctors, I think you'll find that even though some lenses require more time and more skill to be properly and appropriately fitted to your eyes, the quality of your life will drastically improve. And if the only thing I've inspired you to do today is to go home and make a camera out of your watermelon, I feel compelled to advise you of the hidden danger that may come with working with a watermelon. So thank you very much for your attention up to this point.